I work in the Pediatric Survivorship Program at Memorial, and I see anyone who's more than a year off treatment for cancer therapy. So that includes a large number of neuroblastoma survivors, and certainly from a research perspective, I'm interested in neuroblastoma survivors as well. I guess the bottom line is that survival rates have continued to improve in really all higher income countries. And we see data here from Great Britain, which shows these improved survival rates for all childhood cancers, including neuroblastoma, shown here in yellow. And this has really made us think carefully about this growing population of survivors with special healthcare needs. So what are these special healthcare needs? Well, there are really two categories about which we're concerned. The first are called long-term effects. These are problems that occur at diagnosis and/or during active treatment, and some of these resolve and some persist. The second category are what we call late effects. These are treatment-related complications that occur many years after therapy, and they may be clinically silent for a period of time before becoming apparent. And what's important to us is that survivors may be lost to follow-up at that time, and these late effects can sort of pop up seemingly out of nowhere if careful risk-based screening isn't continued longitudinally. So in North America, most of our data on childhood cancer survivors has come from the Childhood Cancer Survivor Study, which is a multi-institutional study which follows about 14,000 childhood cancer survivors who fill out very detailed questionnaires periodically. Here we have the British Childhood Cancer Survivor Study, which is a population-based study in Britain of survivors diagnosed at under 21 years of age and treated between 1940 and 1991. And there are other large European cohorts who are studying survivorship issues as well. So from the Childhood Cancer Survivor Study, which again is our North American cohort study, we know that by 30 years after a diagnosis of cancer, 73% will have at least one chronic condition, and 42% will have a severe or life-threatening condition. And in a smaller study that looked specifically at neuroblastoma survivors enrolled in the CCSS, and again, these are patients diagnosed between 1970 and 1986, so very different from the patients who we're treating and following today, there was, of course, an increased risk of chronic conditions. And if you can see that bottom graph, those who are treated the most heavily are at the greatest risk for these sorts of late effects. So if there's one takeaway point from this talk today, I want it to be this. Certainly there is a risk of late effects for all childhood cancer survivors, but many of these can be detected early before there are symptoms or problems. Many of these are easily treated, some are preventable, and some are modifiable. The majority are not serious or life-threatening. They can affect most organs of the body, and the risk often increases with time after treatment. So for any survivor who comes into our clinic, we really have to think about a constellation of symptoms that influence their late effect risk. And these include pre-treatment factors, which are perhaps less important for neuroblastoma survivors who are really diagnosed at a very young age, genetic factors, which are becoming increasingly elucidated with time, tumor factors such as histology and biology, treatment factors, did the patient receive chemotherapy, how much, radiation therapy, stem cell transplant, immunotherapy, treatment events, demographic factors such as age, gender, and race, health behaviors, do they smoke, how's their diet, are they physically active, do they bake in the sun without sunscreen, and of course it remains to be seen how the aging process will modify the risk of late effects. So what are some of these treatment-related complications that can result from diagnosis and treatment of childhood cancer? Well, I'm only going to highlight a few that I think are most relevant to this population, but the ones I want to highlight are really in 4 categories, and these are endocrine and metabolic issues, those related to vital organs such as the heart or the lungs, sensory and learning issues, and second tumors. So first, endocrine and metabolic complications. These are the most prevalent late effects in survivors of childhood cancer and are observed in 40 to 60% of those who are followed into adulthood. They are most often seen after treatment with radiation impacting the brain and after treatment with high-dose alkylating agents, particularly when administered prior to transplant. So what are some of these endocrine complications? The first is an underactive thyroid or primary hypothyroidism. This is common after radiation to the neck and also may develop after MIBG therapy. There should not be a risk after MIBG used for diagnostic purposes for scanning. And importantly, the risk increases with higher radiation doses. The risk increases over time. It's easily diagnosed with a simple blood test that really should be done periodically in anyone at risk, and it's easily treated with a single daily pill. Other endocrine issues that are very important to the families we follow, and those are related to poor growth or short stature. So this may be due to one of two problems. It can either be hormonal in etiology or endocrine, or non-endocrine, which is related to impaired spinal growth. And in some patients, it can be especially confusing because it can be due to a combination of both. So first, the endocrine issue, which is related to growth hormone deficiency. This is common after brain radiation doses greater than 18 gray, and may also be seen in children treated with total body irradiation. For these patients, height should be plotted every 6 months on standardized growth curves, and puberty should also be monitored carefully because there's also an increased risk for precocious puberty, which can also negatively impact height ultimately. And for anyone who's at risk who demonstrates poor linear growth over time, formal growth hormone stimulation testing should be performed. Now, the other cause of poor linear growth is due to impaired spinal growth, which results from damage to the vertebrae by radiation received either during abdominal radiation, spinal radiation, or total body irradiation. This becomes most apparent during puberty. And in these patients, we actually monitor serial sitting heights, so we monitor the spine at every visit, and there's really no clear data on the utility of treatment for these patients. Moving on to other more recently identified endocrine late effects, it's recently become clear that those treated with abdominal radiation or total body irradiation are at increased risk for diabetes mellitus. So there have been reports of increased type 1 and type 2 diabetes. The mechanism of this process, however, is very poorly understood, and we have studies underway at Memorial trying to clarify this process. But for now, we are just monitoring blood sugars annually and, of course, counseling our patients on the importance of diet and exercise. Fertility is another huge issue. The risk is greatest after radiation to the ovaries or testes, and also there is a risk after treatment with high-dose alkylating agents. In girls, it's a bit easier because we have good blood tests that we can follow, and we can also monitor breast development, the onset of menarche, and menstrual regularity. It's important to know that even for menstruating females who appear to be fertile at any point in time, there is still a risk of premature menopause. And in the States, post-treatment egg freezing is an option for some girls. In boys, however, things are a bit trickier because there are no reliable blood tests or clinical symptoms to follow, and really the only way to know if a boy is producing sperm is to obtain a semen analysis, which most of our young boys are not interested in. So other types of late effects. We know that treatment with anthracycline chemotherapy or chest-directed radiation can result in a weakened heart. The risk increases with larger total doses of chemotherapy and or radiotherapy. Again, the risk of heart problems increases over time. Rarely cause symptoms during the childhood years, certainly, and this is something that's very easily detected with screening echocardiograms. Hearing problems are one of the most prevalent late effects that we see in survivors of high-risk neuroblastoma. The risk is greatest after treatment with cisplatin and may be seen after high doses of carboplatin administered prior to transplant. We know additional risk factors are certain types of antibiotics and higher doses of cranial radiation. Hearing loss in these patients is generally irreversible and typically affects both ears. And we, of course, recommend early implementation of hearing services and hearing aids when indicated. Learning problems are seen in those who are treated with radiation to the brain at higher doses, but of course those treated between the ages of 0 and 5, which is most of our neuroblastoma survivors, are at risk for subtle learning issues as well. So we do recommend very detailed neuropsychological testing and then recommend serial assessments over time to make sure that our survivors are really reaching their maximum academic and vocational potential. Second cancers are rare, but are, of course, a serious late effect. There are two types, the early onset second cancers, which are typically the secondary leukemias that are chemotherapy related. And then, of course, we see late onset second solid tumors as well, which are usually located in the radiation field. Because these are now pretty well delineated, we have specific screening recommendations in place to enable early detection of some second solid tumors. So for those who get high-dose chest radiation, we are recommending early mammograms and breast MRIs starting at age 25 or 8 years after therapy, whichever is later. So in our population, it's 25. We recommend early colonoscopies in those treated with greater than 30 grade of the abdomen. We do yearly thyroid clinical exams for anyone who got neck radiation because there is an increased risk of thyroid cancer, although some centers are doing yearly thyroid ultrasounds, which is a whole different bag of worms because we do worry about sort of over-detection. And then certainly patients should have careful skin exams in all of the radiation fields because there is a risk for non-melanoma skin cancers in any area that's been irradiated. So this I'm just bringing up because it was recently reported specifically in neuroblastoma survivors by Dr. Kushner and other people at our center. So osteochondromas are benign bony tumors. There's nothing to do for them. However, of course, it's very worrisome when a neuroblastoma survivor or any childhood cancer survivor presents with a new bony tumor. So these have been reported for a long time to develop in the radiation field, but we've recently reported an increased risk in neuroblastoma survivors specifically for these benign bony growths both in the radiation field and outside the radiation field. So of course, call your doctor, we want to see you, but hopefully it's not a cause for panic. So while these are some of the most important late effects that we see specifically in neuroblastoma survivors, how can we reduce the risk of some of these problems after treatment is already completed? And my answer to that is really long-term survivorship care. So we know that even though the risk of chronic conditions increases over time, the chance of a survivor being seen in a cancer center as he or she gets farther from treatment seems to decrease. So there's a growing population of people who aren't receiving appropriate long-term risk-based care. But really, the goal for each survivor is to receive individualized risk-based long-term care. And in the US, we really feel that this should be lifelong. And the rationale for the provision of this type of care is that this is a very high-risk population at risk for a wide array of potential problems. The risk does not plateau with aging, and there can be a clinically silent period of 20 to 30 years for some of these problems. And some of these are potentially modifiable by secondary or tertiary prevention and early diagnosis or intervention. So some of these modifiable outcomes we've, of course, discussed already. These include underactive thyroid, which is easily detected with a blood test, cardiomyopathy or a weakened heart, easily detected with screening echocardiograms. Breast cancer, we've shown that we can detect this pretty well with early mammograms and breast MRIs. And diabetes, we believe we can not prevent, but perhaps modify outcomes by detecting this early with screening and really counseling on the importance of physical activity and a proper diet. So we really stress the importance of healthy living. And what we mean by that is regular physical activity, 5 servings of fruits and vegetables a day, making sure that each person gets adequate calcium intake, minimizing carbonated soft drinks, eating a low-fat, high-fiber diet, making sure you wear sunscreen regularly, and avoiding tobacco use. And so, in our clinic, the way we provide this lifelong risk-based care is we monitor for recurrences of cancer, we perform surveillance for second cancers, we counsel on the importance of prevention, and really educate our survivors and their families. So in our program, we certainly are active clinically, but also have a research component in which we investigate the health outcomes and healthcare needs of this population, and also seek to educate healthcare professionals or general practitioners regarding the long-term healthcare of survivors. So we currently follow about 2,100 survivors of childhood cancer. The last time I checked was several months ago. There were 300 patients with a history of neuroblastoma. We follow them till the age of 21, and then we have a dedicated adult program, which consists of adult practitioners who follow adult survivors of childhood cancer for the rest of their lives. The way that we structure our risk-based care is based on the North American Children's Oncology Group guidelines, which are publicly available to anyone at survivorshipguidelines.org. There are, of course, other guidelines. The Scottish Intercollegiate Guidelines Network has guidelines online as well, and so does the UK group, although I think I have to update this URL. There is also an effort now to harmonize guidelines between the US, the Dutch, the Scottish group, and the UK, and hopefully come up with a set of guidelines that's applicable to all practitioners who provide long-term survivorship care. And of course, there's also the PanCare Consortium that is seeking to come up with a set of guidelines for their pan-European network, and that's in progress. So this is what our guidelines look like. You type in any agent that you're interested in, and you can see what the potential late effect is, who's at risk, and how they should be screened. There are also these wonderful health links on that website, which are actually written for families about particular late effects, and we actually print these out for all of our families the first time we see them so that they have the ones that are relevant to their child's specific treatment. And then using these guidelines, or no matter what guidelines you use, I think anyone who provides survivorship care would agree that all patients should have a 1 to 2 page document that's a summary of all the cancer treatment they received. So the way these are structured, this is just a made-up one from our clinic, is the top of the treatment summary is sort of the patient's basic stats, what the diagnosis is, where they were treated, the age of diagnosis, since that modifies risk, and the date of completion of therapy, because that lets us think differently about what patients are at risk for. Surgery, the type that was received, radiation therapy, the dates, the field, the dose, types of chemotherapeutic agents, and the doses are only included when it's important in terms of thinking about ultimate risk, immunotherapy received, and then the potential late effects and screening recommendations. So I always emphasize these are potential late effects. Hopefully none of them will happen, but someone needs to be looking out for these things long term. And if you take this document to a GP who knows very little about cancer or any of these agents, they can at least make sure that your child is being screened appropriately for life using this document. So based on this treatment summary, and based on hopefully at least an initial late effects consultation, we hope that each survivor can answer all the questions on this checklist. And these include, do I know the name of my cancer diagnosis? Do I know the names and doses of my chemotherapy, the site and doses of radiation therapy, and types of surgery? Do I know the long-term risks associated with my diagnosis and treatment? Do I know the tests or studies recommended to look for late complications? Do I have a healthcare provider who's familiar with my cancer history? Do I have regular checkups at least once a year, and again, that is for life? And do I practice a healthy lifestyle, which includes exercise that's regular, a healthy diet, and avoidance of tobacco and other harmful health behaviors? Do I engage in preventative health measures when indicated? And so, in summary, I think it's clear that neuroblastoma survivors face lifelong long-term risks. However, it's important to note that many of these late effects are modifiable, and we hope that each survivor will receive lifelong risk-based survivor care with the aim of reducing morbidity and mortality, educating and empowering survivors and their families, and enhancing quality of life.